For today's case, I'm going to take you through a veneer procedure on the anterior 6. Here's our patient Samantha. Her chief complaint was that she wasn't happy with the 4 veneers placed on her centrals and laterals. I'm always curious why previous restorations were done, so I asked her for a before photo. This is how her natural teeth were. She originally wanted veneers to close the space between the centrals and to correct the incisal shape of the laterals. Now, looking at the restorations she received, they did improve on those aspects. But if we evaluate the teeth with her face and the framing of her smile, they do appear rather small, and the proportions are a bit off, with the centrals wider than they are long. So, besides just replacing 7 through 10, I plan to also place veneers on the canines, as it will allow me to create more aesthetic proportions on all of the anterior teeth. From my diagnostic wax-up, I use a putty matrix and seat the mock-up to evaluate the proportions. Once everything is approved, the mock-up also serves as a guide for the gingivectomies. With the BioLase I+ hard and soft tissue laser, I begin using the laser bandage setting to superficially trace along the areas I plan to remove gingival tissue on numbers 6, 8, and 11. I then remove the mock-up and complete the gingivectomies in a higher wattage setting. You can see I'm using my non-dominant hand to stabilize the head of the laser, as it's important to have steady control as I hover the tip above the soft tissue. And also because I had a little bit too much coffee that morning. Slow and steady movements with the laser will allow you to fillet off the tissue cleanly until the right position is achieved. Next, I switch to a hard tissue setting that allows for removal of old restorations. This works well with veneers as you can access more of the bonded surfaces. On this setting, slowly guide the laser along all of the exposed aspects of the restoration while aiming the tip toward the center of the tooth. This will allow the laser to obliterate the bonded interface between the restoration and the cement. The mechanism is essentially micro-explosions of the water molecules along the cement interface. I must admit, it's pretty satisfying to see the restorations pop off intact once enough of the bond breaks down. Once the old veneers are off, I pack a size 000 cord into the sulcus of each tooth to help drop the tissue down a bit apically. Now we need to clean the preps. I use a fine grit round-end tapered diamond to remove the residual cement. The original preps have adequate reduction, a nicely defined chamfered margin, and rounded internal line angles, so there's not really a need to modify them much. For the canines, I place a light chamfer along the gingival margins and reduce mainly on the distal facial, so the final position of the veneers will blend with the posterior teeth. I finish things off with a Venus super polisher to smooth and round over the incisal edges. To ensure we get a good capture of the margins in our digital impression, I pack a size 1 cord to provide lateral tissue deflection. For the impression, I utilize the iTero Element digital scanner to capture a pre-treatment scan of the diagnostic model, the opposing arch, and the preps. For the prep scan, I remove the top size 1 cord and dry the field really well to facilitate an accurate impression. When scanning, it's much more important to view the screen as you sweep along the incisal, lingual, and facial surfaces to ensure the digital model builds with all of the critical details of the patient's dentition. Remember to evaluate your completed scans before sending them to the lab or your chairside design station. To provisionalize, I use a shrink wrap technique, but I won't spot bond them in place since I'll actually deliver the final veneers the next day. I place a little bit of Gluma desensitizer on the preps and then fill the putty matrix with Luxatemp Bisacryl material. After the material begins setting, I can easily peel away the excess from the scallop borders of the putty matrix. Now in the Fast Design software, the first step is to identify the margin positions. You can see where I position the margins for each prep. The software is then able to establish the designs based on the dimensions of the diagnostic wax-up. Once the overall contours and aesthetics are set, I dial in the proximal and occlusal contacts and then begin milling the restorations out of Obsidian CAD Bleach 4 blocks. Each restoration takes about 15 minutes to mill and then requires a crystallization cycle in the final stage porcelain oven for 25 minutes. Now at our delivery appointment the following day, I use crown removal forceps to carefully break away the temp material and then use an ultrasonic scaler to clean the preps. I try in the Obsidian CAD lithium silicate veneers with Kerr NX3 clear try-in paste to evaluate the final aesthetics. Once everything checks off, we'll proceed with preparing the restorations for bonding. Here we're using a product from Ivoclar called Monobond Etch and Prime, which is a single component ceramic primer that etches and silanates glass ceramics in one step. It's scrubbed in and allowed to react for 60 seconds, where the ammonium polyfluoride etches the ceramic, and after rinsing the solution away, a silane layer remains. Pretty cool stuff. Now it's time to prep the teeth. I always use a total etch or etch and rinse protocol. I apply phosphoric acid to the entire tooth surface for about 20 seconds and then rinse away. This, to me, is still the best way to establish a strong bond to tooth structure. I apply Gluma desensitizer and let it sit for at least a minute and suction away any excess. I then scrub in Kerr OptiBond Universal Bonding Agent into the preps and suction away the excess while I air thin it. We deliver these veneers with Kerr NX3 light cure cement so I can seat all of the restorations down at the same time. I apply lingual and apical pressure using bite sticks while my assistant tack cures each veneer down. After tack curing, I remove as much excess cement with a scaler and explorer and then floss through the contact areas before the final cure. At the end, I dial in the occlusion and also smooth out any rough areas along the lingual margins with a fine grit diamond burr. The outcome provided a great aesthetic improvement that I think fits the patient really well. Thanks for tuning in for this episode of Chairside Live, and we'll see you in the next one.